case I will be reflecting on today involved a 93-year-old female living in a nursing home who had a mechanical fall after going to the toilet. The patient landed on her right side, causing severe skin tears to her right arm and leg. Staff did not move the patient due to query of C-spine injury. After reassuring and questioning the patient, it was concluded that she had to be moved before all vital signs could be taken. This is an extremely relevant case due to the complication of moving the patient. It involved implementing an extrication plan that was viable in the small space of the bathroom, whilst also taking into consideration the amount of pain it may cause the patient. This case is important to reflect on as there are multiple ways in which it could have been dealt with, because when it comes to extrication, there is no set method as every case is different. Along with complicated extrication, this case also involved dressing bleeding skin tears, manoeuvring around the patient's awkward positioning to access her, and being aware of a possible C-spine injury. For this case, we originally planned to move the patient from the floor using a slide sheet onto the combi carrier, then to the stretcher. Getting the slide sheet under the patient caused her a significant amount of pain. It was therefore decided that we would limit her pain with only one transfer from the floor straight onto the stretcher. I used my skills learnt at uni to secure the patient's head and neck during the move by gripping over her ears with open palms. Even though I had never used a slide sheet on a real person, I did have the knowledge of how to use one from uni classes. Due to being a student, I was unaware of different options or useful methods gained from other cases. I did, however, have the knowledge to deal with this case, although it would have been a lot less complicated to handle if I had prior experience with these sorts of skills. The main issue revolving around this case was the difficulty in transferring the patient from where she fell in the bathroom to the stretcher. Contributing factors towards this incident included firstly the patient being extremely frail, hence movement causing her severe pain, and secondly the query of C-spine damage. While still lying on the bathroom floor, we examined the patient in regards to her C-spine. According to the Journal of Trauma and Acute Care Surgery, there are various signs and symptoms that represent damage to your C-spine. Some of these that could have been presentable in this case include numbness, tingling or loss of sensation in the patient's hands, fingers, feet or toes, extreme back pain or pressure in their neck, head or back, weakness, incoordination or paralysis, oddly positioned or twisted neck and back, and impaired breathing after injury. On examination, our patient did not present with any of these symptoms and denied any abnormal sensations or loss of feeling. We therefore still remained aware of her C-spine, however did not have any immediate concerns for damage. I did, however, manually immobilize the patient's head and neck in the neutral position. As stated by the Journal of Emergency Medicine, this immobilization technique stabilizes the patient's neck and spine, preventing flexion, extension, rotation, and lateral bending of the neck. The C-spine caution taken on this case could be questionable. However, the patient was not moved until we were confident of her injuries and had ruled out the immediate concern for C-spine. Also, due to where the patient fell, it was unrealistic to move her in any other way. Our decisions and methods can be supported by the Manual of Clinical Paramedic Procedures, who state, when it comes to the out-of-hospital spinal immobilization techniques, it is not possible to state categorically which methods should and shouldn't be used. After reflecting, it is important to consider what we would do differently if we were to reattend this incident. My main change would be to put a soft collar on the patient before moving her from the floor. This may not have made any difference, however would have been a further precaution for C-spine damage. Referring to the Journal of Physical Medicine and Rehabilitation, a soft collar is a significant out-of-hospital intervention that provides stabilization and limits the neck's range of motion. Due to the patient lying on her side and her skin being extremely susceptible to tears, a collar could be difficult to apply and may cause the patient further discomfort. An important factor to consider in this reflective process is that the patient was GCS 15, able to talk to us and recall all events. It is beneficial for future practice to consider what might have happened if the patient was unconscious or did not have the full capacity to answer our questions. In terms of C-spine damage, we would have been more cautious, being unable to determine the severity of her fall and injuries. Further caution would have required us to use a soft collar and combi carrier when moving the patient. Referring once again to the QAS Clinical Practice Procedure Guidelines, the combi carrier is designed for use in extrication of patients while assisting in maintaining immobilization. By reflecting on this case, I now have further understanding for future cases in terms of moving elderly patients after falls and the aspects to consider when developing an effective extrication plan.